Thank you very much, Laszlo, for the introduction. I'm going to talk to you about medically unexplained syndromes, but before doing that, I need to respond to Mike Sperling's excellent lecture. I would like to say two things that he mentioned. One is that there is class 1 evidence supporting the DBS is better than the best medical therapy, and I guess by that he talks about oral tablets because there are alternatives to DBS, and these are both apomorphine pumps and as well as intraduodenal levodopa, carbidopa infusions, and these are just as good as DBS. If you will hear, I mean, both of these will be presented at this meeting, so I think that it should be remembered that these are by and large as useful as DBS. And the second is when talking about thalamic stimulation for epilepsy, we should also remember that there is the option of thalamic involvement in tremor. The thalamus has been an old target for tremor control, and you will hear here about not electrical stimulation, but rather ultrasound lesioning of the thalamus that is very effective in treatment of ET and possibly other movement disorders. So this will be done during the Saturday Parkinson session. So with this, I will go to the topic of my talk, and I'm going to tell you what I think about or how I look at this issue of medically unexplained syndromes and why I think that it's important. At the onset, I say that I don't have solution to many of the issues that I will present, but I want to discuss with you and to hear your views maybe later on about the way I see these things. So what's in a name? So what we call medically unexplained syndromes had different names over the past: neurosis, neurasthenia, hysteria, hypochondriasis, conversion disorder, somatoform disorder, bodily distress disorder, central sensitivity syndrome, and so on. And now in DSM-5, somatic symptom disorder, and as well as illness anxiety disorder, but I will use the term medically unexplained symptoms. Older terms for medically unexplained syndromes were hysteria or labile indifference, royal free disease, myalgic encephalomyelitis, still commonly used in England, shell shock, and temporomandibular joint dysfunction. Of course, in the military usage, soldier's heart, combat fatigue, shell shock, Kriegsnervose, and now PTSD as the most modern term that is used. And other medically unexplained syndromes that we have now commonly used: fibromyalgia, systemic exertion intolerance disease, regional pain syndrome, tension headache, chronic low back pain, sorry for the typo, dizziness, chronic fatigue syndrome, Münchhausen syndrome. And therefore, medically unexplained syndrome is a meta-diagnosis. And it is a very common problem. So data show us that maybe 30% of patients who come to their GP, to the general practitioner, suffer from, should be termed, medically unexplained syndrome, although this term is not frequently used as a diagnosis. Let us also be modest and remember that duodenal ulcer was considered to be a medically unexplained syndrome until the cause was discovered, and it's an organic cause. So the fact that that it's medically unexplained does not mean that it cannot be explained. By and large, when we say medically unexplained, we mean a different thing. So these are, as I said, major causes of referral, and not always benign. So if a person comes in with a stroke to the hospital and gets a TPA injection, and then turns out that they never had a stroke, and these things happen in all centers, then this is an expensive procedure, this is a dangerous procedure, and we should be aware that these things happen. And of course, the same is true for status epilepticus, where in some cases it is status pseudoepilepticus, and the patients do not have electrical discharge, but when they come in with this severe condition, they are referred to all kinds of treatment, including general anesthesia and so on, and this can cause them severe damage, including their lives. So there are not these medically unexplained syndromes are not only common, but also maybe lethal. So what we call medically unexplained is really a euphemism. Really, what we mean is that they are medically unexplainable. Most of the things that, most of diagnoses, most of the diseases that we talk about are not completely explained in biological terms. But here we're talking about a different sort of things. Now we're talking about things that we think in principle we shall not be able to explain on a biological basis, and I note the exception again of duodenal ulcer and others that I have mentioned before. And this, what we say, when we talk to each other, we say it's all in their mind, there is nothing really, and this is really the basic issue that we are facing. It's a mind-body problem. And basically, this is a question that is philosophically very old of monism versus dualism. Do we speak about the body and the mind as one unit, or do we separate them into two? And this is an old story. So in terms of the arts, Imaginary Illness by Daumier, Molière, of course, La Malade Imaginaire, again Molière. So the diagnostic requirements to say that something is medically unexplained is that firstly, and we're talking about neurological disorders, of course, can be done also in other fields as well, is that we exclude as far as we can a neurological disorder underlying this. So we do all the studies that we can, neurological examination, CT, MRI, PET, what have you, functional MRI, and we don't find an explanation, then we say that this is medically or neurologically unexplained, and again, what we mean is that unexplainable. And of course, we have to exclude feigning in different ways. And the third requirement, and it's in small font, is establishment of a psychological mechanism. But usually, mostly, we do not find or we do not have a psychological mechanism, and I will come back to this later. So actually, this is a diagnostic by exclusion. And it's always difficult, always dangerous to make a diagnosis by exclusion. Of course, history teaches us a lot, and Jean-Martin Charcot, an eminent neurologist and maybe psychiatrist in France, he coined or he used the term hysteria and established it, and was later promoted by Sigmund Freud. Charcot always believed that what he saw as hysteria is an organic disease, and he was trying to find out, didn't have an MRI, but he did have autopsy to try to identify the lesion that causes this problem, and unfortunately, and obviously, he failed to do so. Sigmund Freud, a neurologist, went over to the other side and said, no, there is nothing wrong in their brain matter. It's only in their psyche. So what do we mean by a psyche being different from the brain? This is the issue that we are all facing in this difficult problem. DSM-4 defined the label d'indifference as a relative lack of concern about the nature or implication of the symptoms. So the person may be paralyzed, but he's not really worried about that. Here is the famous drawing of Charcot, and eminent people here. This is Babinski. Babinski was his pupil, but then disregarded what Charcot was saying. In the audience, I'm not going to point all of them, but very eminent people, including Gilles de la Tourette and others. And Axel Munthe was also there, and those of you who read, and I'm sure many of you have read, The Road to Saint Michel, he said, like Babinski, that actually these women, Blanche here, were not really diseased in their internal. They were made to mimic or to this position by Charcot. So he made them pretend in a way, unconsciously, not consciously, to behave in that way. So he said, but this is again an issue. So by turning their mind, the mind of these people, to behave in a certain way, he caused their body, their physical symptoms, to appear. The symptoms, the rebellion difference in conversion symptoms and hysteria, systematic review, and other things show us that actually what we look as clinical neurologists, I assume most of us here are clinical neurologists, as hysterical signs and symptoms. So we look for the split middle in hemihypoanesthesia and so on, are not really very good indicators. And here is a bar graph, and I don't want to go into each of these details, but in patients who do have organic disease verified by CT or MRI, many of them would fulfill criteria for hysterical, what we call hysterical symptoms. So we should again be modest in our clinical examination and interpretation of what we find. Again, in neurology, we always speak about positive symptoms and negative symptoms, weakness is a negative symptom, and then their spasticity is a positive symptom, and so on. And this also occurs in the context that we are talking about. So labellian deference is one example of denial of illness, which we call psychiatric. We call this is due to disease of the mind. But anosognosia and Anton syndrome are also the same thing. They are also, these patients do also deny their symptoms. They do not admit to be blind or to be sick or to be hemiplegic, and yet in this case we think that this is organic. So again, why is it that we call one organic and the other functional? Is because in anosognosia and Anton syndrome we can identify the lesion in the brain, whereas in labellian difference there is none, or apparently there is none. But also there is denial of illness in other contexts. So all patients with schizophrenia and paranoia, most of them anyway, deny that they're sick, and we say, we know better than you, or you suffer from these thought abnormalities and paranoid ideations, and we know that it's all in your mind, it's not real, and the fact that you deny the illness only proves that you are sick. And the same is true for young women with anorexia nervosa, and the same we see also in patients with dementia. But here again, we look at it differently. We separate the denial of illness of schizophrenia, paranoia, and anorexia from patients with dementia for good reasons. But just the fact that a person denies the illness is not by itself a good indicator of what we're talking about. And of course, psychosomatic disorders also should be considered. So asthma, irritable bowel syndrome, sexual disorders like impotence and dyspareunia, which are so common, we call them psychosomatic. So what do we mean by the term psychosomatic? Again, we mean a separation of mind and body. We say that the mind of these patients affects their body in this way to create this. Why is it so? What are the mechanisms? We're totally ignorant and cannot explain why this person developed asthma out of whatever mental mechanism or derangement they have or not, or did not have. And the context is that, of course, the mind can affect the body. And we know that this is so in mental states, like hysteria. But on the other side, placebo are the other side of the same coin. So if we use placebo, or if the patients respond to placebo, and we just heard in the previous lecture about how many times patients respond to placebo rather than to the actual treatment, then this is again a manifestation of how the mind, just the belief that something is going on which will benefit you, will cause your body to respond in a favorable way. So again, the mind and the body are the key issues that we should discuss here. And we use the terms organic and functional. And again, I want to stress that this is a negative definition. We call something functional when we don't find, we cannot identify an organic basis. So tension headache, many of us think is a functional disorder, as opposed to migraine, which we've heard this excellent lecture just now, which we all are sure is an organic disorder. And I wonder why. Why is it that migraine should be considered an organic disease and the tension headache is a functional disorder? And perhaps the best convincing evidence that migraine is an organic disease is the fact that we found treatments for this. So the fact that we have organic treatment for a disease, be it the triptans or being now the CGRP antagonist, this gives credence to the idea that this is an organic disease. So it's not the actual disorder that we are seeing, but rather the response to treatment that we have been able to find. And if somebody will come up with an excellent treatment for tension headache, a drug or otherwise, then we shall say, okay, so this is also an organic disease. Pseudo-seizures, again, these are organic. No, these are not organic, because why not? The EEG tells us so. I mean, clinically, clinicians, the best epileptologists around, and if you will come tomorrow to the epilepsy session, at the end of the day, Michael Sperling will show you cases, and you will see that the cases of pseudo-seizures that I assume, I don't know, will be presented there. The experts in the field who are there will not be unanimous in identifying phenomenologically whether these are whether these are real seizure with EEG corroboration or whether these are functional. And I might also say that the fact that we say that these are pseudo-seizures are not real, are not organic, does not mean much, because the patients have seizures, and the seizures come from the central nervous system, maybe not from areas that can be explored by the EEG, but there is abnormal activity, electrical activity there anyway. So why do we say that this is organic and this is non-organic? Not clear. So the dichotomy that I mentioned, the organic being neurological, identical to neurological, and functional being referred to psychiatrists, is a truism. We use it all the time. But what do we do with things like post-traumatic stress disorder? So here we have an obvious psychological stress causing this, and yet all of us, I think, will accept that there are changes in the brain. There are actual changes in the circuitry of the brain or whatever that causes this. So is PTSD organic or is it functional? Is it functional in its origin and organic in the pathophysiology later on? So again, functional being a negative definition, that is lack of an organic explanation. So is it correct to say that functional equals psychogenic? The assumed underlying mechanism for functional will be what Freud used to say, resolution of internal conflicts, or maybe secondary gain, or maybe stress, or maybe depression. None of this is validated. None of these underlying mechanisms have been supported by actual data. And if we see, so if we send our patients with, let's say, pseudo seizures to our psychiatrist to try to help us, because we have now proven that these seizures that these patients have are non-organic because the EEG is normal, and they say, the psychiatrists may say that the person is completely normal in many cases. In others, they would say that this is due to the patient is obviously depressed or anxious. But the fact that they are depressed or anxious now does not mean that this caused the disease. Association does not prove causation. Of course, if I would develop this untreatable disease where I will have seizures coming out of the blue without any cause, I may become depressed and stressed. And psychiatrists may say that I'm depressed and stressed. This does not mean that the depression caused the problems. The role of stress as a causative is, of course, obvious in post-traumatic stress disorder and maybe in what we call mass psychogenic illnesses. But in most other cases, we don't have any support for the idea that any of these medically unexplained or neurological unexplained symptoms are really due to stress. So, is medically unexplained symptom a single clinical entity with different expressivity? Functional symptoms do not have any commonality. So a patient who has irritable bowel syndrome or pseudo seizures, what's common to them? They are both regarded as medically unexplained, and yet they are completely different in the phenotypic presentation. If we look at paroxysmal non-epileptic seizure and functional movement disorders, these are both paroxysmal paroxysmal episodes. And what is the difference between them? Why would a person develop paroxysmal non-epileptic seizure and another person develop functional movement disorder? This is absolutely not clear. Sometimes there is an indication. In some patients, we can see that this patient who had non-epileptic seizure saw patients with epilepsy in their life. Not really, again, we see this anecdotally, but this is again non-validated, and I think that by and large, this idea is not supported by data. We don't understand why these symptoms will appear, and we definitely don't understand why now. What happened? I mean, there was no acute change that caused this person to develop this paroxysmal non-epileptic seizures or movement disorders at this point in their life, at the age of 16 or 35. Why? Why then? Why not before? Why not later? And the most common unexplained symptoms that are not frequently referred to us, maybe they're seen by the GPs: dizziness, headache and pain, fatigue, sleep problems, globus hystericus, not as common anymore. And again, why do patients develop different symptoms? What is the mechanism that underlies this? We should, of course, make a difference between medically unexplained symptoms and malingering. Malingering is a different story. Factitious disorders are also, and somatic symptom disorder is the modern equivalent of hysteria. Are these differences really valid? I want to mention that this issue of secondary gain in the context of cognitive dissonance. So if you go to a prison and you look at all these convicted prisoners there, they have all made, some of them, terrible things. And you ask them whether they feel that they are wrong in what they did, very few of them will admit it. Most of them will say there are reasons to this. And this is a manifestation of what the psychologists call cognitive dissonance. And I am sure that this is also true for patients who have factitious disorder and even those who are clearly malinger and know that they malinger. But they say there is an explanation. It's not truly true that we're doing it. There is some truth in this that maybe we excel. So it's not a black and white thing between the malingering and somatic symptom disorder or hysteria. It's all kinds of shades of gray. When we talk about medically unexplained, we refer the patient to psychiatrists. We assume that it's psychiatrically explained. And I already alluded to that and told you that in most cases, the psychiatrists cannot explain it. They can tell us all kinds of theories, but no explanation. And over the years, first they thought that the reason that patients had these manifestations were in the uterus. Then they climbed up and said, well, maybe this is a gallbladder. Then they went further up, and now we say that this is supratentorial. But the evidence for each of these is the same. There is no concrete evidence. Now we say, okay, Syria is out of the picture, of course, mainly because men also suffer from it sometimes. Hypochondriasis, of course, abused term. Supratentorial. This is a derogatory term. This does not explain what goes on. So it's all in your mind. This is a reflection of the mind-body problem of monism versus dualism. And this is an old story. René Descartes was the original or one of the main dualists at the time, and shortly thereafter, Baruch Spinoza, a Portuguese descendant who worked, of course, in the Netherlands, was a monist and say it's the same thing. So whereas Descartes said there is this homunculus which resides not in the cortex but within the pineal, Spinoza had a different view. He says it's all one. So if you speak about dualism, you're a Descartist, but also if you refer your patient to a psychiatrist, you are dualist as well, because you say it's not in my mind. So where is the mind if it's not in the brain? If it's in the brain, this is our neurological domain. Why do you refer it to people who don't understand what goes on in the brain really to try to solve the problems for us? So this is the issue of monism versus dualism. So finally, is medically unexplained syndrome a disease with phenotypic heterogeneity? A question that we don't know. The cause is unknown, and possibly the syndrome is multifactorial. There are almost no data on the natural history of medically unexplained symptoms, and there is no treatment of proven efficacy for any of these. And the take-home messages for me are, firstly, that the diagnosis of medically unexplained symptom is made by exclusion, which is always a problem if we make a diagnosis by exclusion. Let us say diagnosis made by exclusion, this diagnosis should be made with great caution, that prospective studies show that some, most cases, turn out to have an organic basis, but only very, very few of them. That the assumption that all most cases reflect psychiatric disease is unproven, has never been proven, and it's just of our convenience that we refer these patients from treating them to our colleagues in the Department of Psychiatry. But the assumption that medically unexplained symptoms has a psychiatric etiology infers philosophically dualism. And I think that this is an important thing that we should take in our mind. And with this I will finish, and again,